So I want to say first that Heidi and I, for example, are clinician researchers. So there's an overlap already that we see patients, both of us see patients, adults with cerebral palsy, and we also participate very much in research. But there are, the clinician is out, so to speak, in the field, in the clinic, and seeing the patients. And when we see the patients, that generates questions. We wonder about the interventions that have been passed on to us through tradition, through the scientists through the physicians that we've worked with before. We wonder about the literature that we read. We wonder about how those things really work. For example, there's so much literature about children with cerebral palsy, and Heidi and I, as we developed our practice in adults with cerebral palsy, always wondered about how do these interventions work with adults with cerebral palsy. And then there's so many unknowns. So as a clinician, we're constantly faced with things, and we get questions. The people in this audience ask their doctors questions all the time. And we say, we don't know. And that's where we really interact with researchers like Dan Whitney and Mark Peterson. And we go to them and we say, here's the questions that keep coming up. Here's the issues that keep coming up. And we work together with that to try and figure out ways that we can solve those questions. What's also interesting is that researchers like Dan and Mark, they help us generate questions in that sometimes we're seeing things and we think we understand them, but we don't really know until we start getting into more in-depth questions, in-depth discussions with the people that are much more heavily involved in research. Dan, for example, has a tremendous expertise in bone structure and physiology. And he started to talk to me about issues relating to bone. And I started to think, well, I never thought about that. And I never really occurred to me that things would happen that way. And especially people with innovative minds like Dan and like Mark, who really look at the clinical questions that people like Heidi and I put on the table and really turn them in a certain way that makes them more interesting. I'll give you just one example. Dan led the effort to on a paper that we wrote, which looked at the how often adults with cerebral palsy, actually people with cerebral palsy all across the lifespan, get fractures. And we generated some graphs that showed how common it is for people of different age groups to get fractures. And when I looked at them, I said, wow, I know that people get fractures, but I never realized it was that much of a problem. So working with researchers really opens up the clinician's eyes in terms of understanding some of the things that they see that we see on a one patient a day basis. It can really help us to see it in the whole group of the population to really understand the problems and understand the problems better. Also, there's many times that we do things and we just know they work because we've done them all the time and we were taught that they work. And the researchers help us to ask questions like, well, do they really work? And sometimes we say, well, we don't really know. We don't really know how to know if they really work. And the researchers have the techniques and the science to help us to understand how we can put tools in place to help us to understand if the things that we're doing really, really work. So in that way, we work as a team to really give the greatest benefit to the people that we serve, which is really what it's all about. So Dan, do you want to make a few comments on that?
Yeah, so on the other side, I often find myself really relying on my clinical colleagues to help put into perspective, is what I'm doing, does it make sense? Is it clinically relevant? Is this on a pathway that's going to be helpful? Or am I wasting my time and just asking interesting questions that's not going to be fruitful? So, I involve my clinical colleagues at different stages of the research phase. Early in development, I'll work with Heidi and Ed quite a bit. Is this something we want to explore? What are you thinking about this in the clinic setting? Are there questions you have? Are there conundrums that you're trying to figure out? And sometimes it's helping just to interpret something or design a certain analytic method to really address something clinically relevant.
That's really fascinating to hear. I know just in working in this role, I've talked to researchers and clinicians, and I think that the symbiotic relationship that you guys are talking about really helps to serve the whole CP community. So I appreciate that it's such a dialogue back and forth, and that each kind of side of things is informing the other side, and it only serves to help us even more.
And Justin, it's very important to point out that there's another member of the team, and that's you and everybody else on this call. And the Cerebral Palsy Research Network did a seminar and a program where we did a generated research questions using people with lived experience and researchers and clinicians and combinations of those things. And just from the interactions that you and I have had, Jocelyn, it's like I'll think something is important, and I remember the conversations we've had, and you'll just tell me that well, maybe not so much, or maybe something different, that kind of thing. So we need a big team to really make this work.
Oh, that's true. Thank you for that excellent point, Ed. Appreciate it. So I'm going to move on to the next question I have for the panel, which is, what drove you to either this practice area or this research area?
Heidi?
So I'm a physiatrist, so I was trained in physical medicine and rehabilitation, and worked with Dr. Hurwitz during residency, and he introduced the idea of what happens to adults with cerebral palsy as they age. So I learned from him and became very interested in using my skills in an area that's been relatively underserved. Like Jocelyn, you mentioned, it's really hard to find people who know enough about it. So it fit well with my interest in rehab, where we focus on improving function and helping people function in their daily lives. And I had a great mentor with Dr. Hurwitz, and then we had the group to work with. So it was a good fit.
Great.
Dan, would you like to comment?
Oh, sure. So I don't really have a very personal or touching story. After undergrad, I had the option to go to West Virginia University to study the biology of neuromuscular aging in the elderly rats, or University of Delaware to study musculoskeletal development in children with cerebral palsy. And the University of Delaware offered the better scholarship. So while it was not a very touching story to get there, it didn't take me long to really fall in love with working with these kids, working with these families. And I was shocked to find out that there's so little information for these families on what's going to happen to their child as they grow up throughout their adult lifespan. And so it was pretty quick. It was pretty quick for me to transition and be quite motivated to want to set my career to start answering these questions.
I just like to tell my story that I was treating children with cerebral palsy for over about 20 years, and then I became the chair of the Department of Physical Medicine and Rehabilitation. And with that, I had to cut down my clinic population. So of course, I kept the patients that I knew best, and I realized suddenly that I had a clinic full of adolescents and adults, because those are the patients I'd known for those 20 years. I still see some children, of course, but I had this population of patients that were older than children. And I realized that I didn't exactly know how to answer their questions, and started to look at the literature, and son of a gun, there wasn't any. There just wasn't any literature. So I'm very thankful that we've put our work together here at the University of Michigan, and we've changed that. We published many articles as a group. Dan's been a tremendous leader in publishing, Mark Peterson with him, and we have really added to the information, but got interested in it because of the absence of information to help us understand what we needed to do next in clinic.
I appreciate all of your stories, and Ed, your segue into the next question works really well, because I want to know what projects everyone's working on that you feel people should know about.
Dan, why don't you go ahead and start?
Yeah, so some of my work has shown that kidney disease is surprisingly prevalent and occurs earlier in the adult lifespan for individuals with cerebral palsy than what we would expect. Now, poor kidney health is significant. Now, what I mean by significant is that kidneys are integral to the health of other organ systems. So when the kidneys are not functioning as they should, this increases risk for health complications in the cardiovascular systems, metabolic health, and even bone health. So I will answer this question in this webinar, and I hope I can provide you, the audience, with some information that you can take with you to your healthcare providers to improve your care. So kidney health is clinically assessed from routine blood work. You go to the doctor, you get your blood drawn, and then there is a laundry list of biomarkers that get analyzed. One of these biomarkers is called creatinine. Your creatinine level gets put into this fancy mathematical algorithm, and this estimates your kidney function. Now, higher kidney function indicates better kidney health. In the way the algorithm is developed, the lower the creatinine, the higher the kidney function, and again, the better the kidney health. Now, the majority of creatinine is produced by the muscle. So herein lies a significant problem for individuals with cerebral palsy. The lower muscle mass leads to a lower creatinine, which leads to a higher estimated kidney function. But this higher estimated kidney function is not actually representative of your true kidney function. So the interpretation is that your kidney health and function is better than it actually is. Now, accurate assessment of kidney function is really important. Some medications can be harmful to kidneys only if the kidneys are already slightly or largely impaired. So depending on your kidney function, your doctor may prescribe certain medications, or it may decrease doses of other medications that are not necessarily for your kidney health, but for other health systems. Doctors may also wish to focus on controlling other medical complications that could worsen your kidney health, like a more aggressive management of high blood pressure, a decrease in inflammation, or better management of diabetes. So I've got bad news, I've got good news, and then I've got really good news. So the bad news is that your primary care physician may not be thinking of the muscle mass issue when interpreting your kidney function from these routine tests, because they have a lot of biomarkers to go through. They'll see it's in the normal range, they'll check it off, they'll go to the next thing. The consequence is that they may not be following up with appropriate kidney care that you might need. The good news is that if you inform them of these muscle mass issues, they're doctors, so they'll understand the medical reasonings. It'll click very quickly. The really good news is that nephrologists, which is the fancy term for kidney doctors, are fully aware of the muscle mass issues and kidney function. In fact, they have several different types of strategies that better assess kidney function and monitor kidney functions for individuals with low muscle mass. So the barrier, or really I should say the addressable barrier, is simply getting to the nephrologist, which hopefully can be done by explaining these issues to your primary care physician at your next visit, who would then refer you to a nephrologist, hopefully. Now, I don't want to raise any alarm. These issues are not immediate. They're not urgent. Kidney decline is part of the aging process, and it is slow. So I hope this information is helpful. It should not concern you, but rather hopefully empower you to take more control of your kidney care.
Dan, oh my goodness. Thank you for all of that and for giving people a tangible way to address it, or at least just even mark it in their mind for the next time they go to their primary care doctor. That is, I'm always thinking CP is this motor neurological disability, not thinking, oh, my kidneys. Like, I would never think to put an extra monitor on that because the test would be off because of my CP. It's like a Rube Goldberg machine of like, you don't know what's affecting everything else. So really appreciate the highlight on the actionable steps there.
Yeah, absolutely. Happy to.
Thank you.
Let me make a comment on this, Jocelyn, in terms of the thing that I'm spending a lot of time right now is with the Cerebral Palsy Research Network. This is a network of 30 medical centers that are working on entering data into the computer when I see somebody in clinic. It's just as part of the clinic appointment, just asking them questions and putting the data in. And I'm leading an effort with some of the people that work with adults with cerebral palsy. We have about half a dozen centers, maybe more, that have people identified that they want to work with us to gathering data for adults with cerebral palsy. So we want to use this as a tool to answer a lot of questions. At the work at University of Michigan, we've done a lot of work looking at risk of chronic disease, heart risk of fractures. I said Dan's led a lot of that work. Dan's led some papers on mental health issues. There's a lot of issues that come up, but we'd like to really study them as we see them going forward in a population. And that's one of the goals that I'm working on. I'm also working with this group on a study that looking at hand grip strength, because hand grip strength turns out to be a great way to measure overall body health and, in a sense, some of the risk of chronic disease that people have. So we want to look and see if that really applies in cerebral palsy, so we can have some way of trying to understand what kind of risk people have with the cerebral palsy of chronic disease as they go forward in life, so that we can help them and guide them and think about when's the best way to do what kind of care at what age. Some of the work that we have going on with that, which I think is very important and hopefully will develop into great things as time goes on.
I never knew that about hand. See, I knew I was going to learn something tonight from all of you. I never knew that about hand grip strength as an indicator of overall health. Are you looking at it in all of the GMFCs levels?
We are actually trying to do that. Yes, we are. And we're looking to see if it makes, what level of grip might make a difference depending on what level of GMFCs a person's at. People here in the audience may have heard of the GMFCs. I don't know if people have heard as much as the MACS, the Manual Abilities Classification Scale, which classifies people by their hand abilities. And we're finding that that may be a greater determinant of what the hand grip can tell us. There's actually some people that are GMFCS4, they're wheelchair users, but they're very, very powerful in their upper bodies. So, it may not go according to GMFCS.
Thank you for that clarification. I had heard of the MACS, but had forgotten about it. So it's useful information for me and everyone else listening. Heidi, did you have something to share as well?
Sure. Yeah, Mark and I have worked some on looking at pain and opioid use, and I was going to talk about it a little more later. But I think we know that many adults with cerebral palsy have pain. It's one of the things that has been identified through research, but Mark and I have really worked with, and Dr. Hurwitz we've worked with some other pain specialists to look at this in more detail, to understand the types of pain and better understand how we can treat pain, because pain can be treated differently depending on what's causing it. And I think that's a really important area for our patients, because just giving pain medications without understanding why there's pain, you may not get to the underlying issue, and there's risks of medications. And Dan and I, we have a paper about polypharmacy, which is prescribing more medications than a certain number, usually sometimes 3, sometimes 5, but the more medications you have, the more risk of drug interactions and negative side effects. So it's something that's very important to be aware of, especially when we're talking about the effects on organs like the kidneys and the liver. Mm-hmm. So
yeah,
that's some of our research.
As one of the people who's in the 75% of folks with CP who experience chronic pain, I deeply personally appreciate any research into chronic pain, and love that work dovetails with one of the research priorities here at Cerebral Palsy Alliance Research Foundation. So I have one more question for the panel, and then we're going to open it up to Q&A. What issues are you seeing that you're motivated to address via your practice or your research?
Justin, I think one of the main driving issues for me is the limited capacity of care for adults with cerebral palsy. By that, I mean that there are just not enough physicians that are knowledgeable, physicians, therapists, and so forth, that are knowledgeable about the issues relating to cerebral palsy. So much of the work that we're trying to do is to educate people about this, but we're trying to think about some different ways that we can get out and really reach out to more people, educate more people. So Mark, for example, is going to be leading an effort to put together a multidisciplinary group to write guidelines for care for adults with cerebral palsy. It's a very exciting effort, and we hope it would be something we can disseminate and make a real difference. Telemedicine is a mechanism that we think can be important for reaching out. So, for example, if there isn't somebody in your neighborhood who has knowledge about adults with cerebral palsy, perhaps there's someone that you can reach out to through telemedicine. There's a lot we can do through telemedicine. We can't tell how spastic your arm is, but there's a lot we can talk about and tell you and work with you on. There's a lot of issues with adults with cerebral palsy that are the, just like everybody else, but a lot of things that are different. And, Dan just led a paper, maybe I should let Dan talk about it in terms of some of the issues relating to preventative care. And we need to educate people about that. So getting more people educated about the needs of adults with cerebral palsy and the differences in their care is a real passion. Dan, do you want to say something?
Yeah, I can go. So, one of the things that I'm interested in and I'm excited about is while the field is generally aware of musculoskeletal issues among individuals with cerebral palsy, we actually know very little of the developmental, biological, and aging processes. So as we are beginning to dive deeper with some of our own work, we are starting to see that the skeletal system is being built differently during childhood and it's possibly aging differently, not just faster, it's just different. So understanding the mechanisms of bone development and how the bone is maintained across the lifespan can tell us more about the sort of therapies that we can use to optimize bone health. And so far, in our early preliminary studies, we are starting to see that we may need to be considering different therapeutic approaches than what is currently being applied to prevent and treat bone fragility for individuals with cerebral palsy.
My goodness. Just opening my mind tonight to all this information. Heidi, was there anything else you wanted to add?
Not too much different. I think, like Dr. Hurwitz, one of my biggest concerns is just knowledge translation and spreading the knowledge to care providers across the country and the world on how to care for adults with cerebral palsy. I think it's so important. And even just trying to educate primary care providers. There's many great primary care providers out there, but just to understand what is different with cerebral palsy and then what just has to be done the same, or maybe at a slightly earlier age for routine health screening, as we're noticing with some of these secondary conditions like the high blood pressure or the metabolic issues. So it's really important. And many of my adults with CP do have very good primary care doctors, but some still have seen a lot of specialists, especially as they're in young adulthood. Right. And do not have a regular primary care provider that they see. And often I get the question, well, can't you be my primary care provider? And I'm a physical medicine doctor and a specialist in that area. And I am not somebody who's trained in when do we screen for hypertension? When do we screen for colon cancer? And how do we do the most updated recommendations for all of the routine health screenings and health maintenance? So I think it's important to educate providers and families about that, but also then when do we send, what do specialists offer and when to send to a specialist, and what can different specialists do to help optimize the health of all of our patients.
It really has to be an open relationship. And I think that, the guide that your team is working on, Mark is working on, really will be incredibly helpful for primary care physicians, because in my experience, and I guess the cumulative experience of my friends with CP and others I know with CP, sometimes we're told, oh, that they'll attribute everything to your CP or they'll attribute nothing to your CP if they don't know anything. And so that's a fun little paradox to have to navigate. So I'm excited to hear that this guide is in the works. And we have a bunch of questions that have come in live. We also have a bunch of questions that came in when people registered. Just a foundational question. Someone asked, what is GMFCs? So if one of you wants to explain that a little bit more clearly than I might, you can go ahead.
You want to take that?
I can take it. So GMFCs is a measure. It stands for Gross Motor Functional Classification System. But really, it's just a way to describe somebody's function and the way that they, for mobility. Do they walk without any assistive device? Do you use a cane? Do you use a wheelchair? And the scale goes from 1 to 5. And it just describes if you're a GMFCs 1, you walk without any difficulties, and then it gets more and more difficult till 5 is somebody who uses a wheelchair and needs to be usually helped with all the transfers and everything.
Thank you for sharing that. I'm not sure that I fully understood GMFCs until I worked here. So I think it's great for people with CP and their parents and caregivers to know as much as possible, so that when you're in conversations with your own clinicians and physicians, you're as informed and understanding as much as you can. Another question in our live says, some CDC-funded patient registries, e.g. spina bifida, are reliant on chart reviews, so they're labor-intensive and expensive to operate. Other longitudinal studies, like the PRIDE study, have relied on patient-reported outcome assessments, which can be administered electronically and or integrated into electronic medical records with lower cost and staffing burdens. Is there any national momentum toward large-scale patient-reported systems?
The answer is momentum might be too good a word. There's direction, there's interest. So the Cerebral Palsy Research Network, for example, is doing some work with patient-reported outcomes. The network has a website called mycp.org, which I encourage everybody to take a look at. And it has some studies that were based on using patient-reported outcomes. We work on putting patient-reported outcomes into our data collection. So there's that. So yes, some of the large, that's on a nationwide basis. It's not quite nationwide like you'd find in a real national registry. It's a growing registry, and hopefully will be someday a real nationwide registry. But I think people these days really understand the importance of patient-reported outcomes. In Michigan, we have a whole project called the Center for Clinical Outcome Measured and Development and Analysis. And it's working on patient-reported outcomes, especially the PROMISE measures, which are the patient-reported outcome measurement instrumentation system, something to that effect. Mm-hmm. Something we all understand is important.
Thank you for that. So this is in a completely different vein, but I think it's an incredibly important question. Sometimes it's hard for kids with CP to gain weight. Then it becomes hard for adults to lose weight, and even adults in a typical weight range could be considered obese based on their body fat percentage. Can you share more information or perspective about the paradox of weight with CP?
Heidi, do you want to take that?
Sure. So yeah, that is always a challenging question, right? As you grow and develop, first of all, you're focused on putting on a lot of weight, and then we worry about obesity and all the consequences of it. And one of the things to understand is that with cerebral palsy, as Dan alluded to earlier, is that your entire musculoskeletal system develops differently. So the muscles develop differently, the bones develop differently. And when you look at those systems, the relative amount, the percentage of contribution to your weight from your bones and your muscle and the fat is different than with somebody who doesn't have CP. So when your muscle mass is lower, your bone density is lower, more of your weight is made up from like fat. So then you worry about the obesity. And so those typical measures like body mass index don't work as well for somebody with cerebral palsy, just because your body proportions are a little different. So it's something to be aware of. In this situation, when we talk about, it's sometimes called normal weight obesity, mm-hmm. is common in other populations, not just in cerebral palsy. It's recognized in other ways, but it's just understanding that your body composition is different when you have cerebral palsy and your system has developed differently.
Thank you.
Dan or Dr. Hurwitz, did you have anything else to add?
Actually, I was going to ask Dan, did you want to say anything else about body composition and weight in cerebral palsy?
Yeah, I can take it from the researcher's perspective. One of the things that we're wondering is, how do you even measure body mass, and what is body mass relevant to cerebral palsy, especially when you're interested in looking at obesity risk. What Dr. Haplo was saying is you have body mass, and it's made up of two components, fat mass and fat-free mass, if we want to simplify it. Cerebral palsy, low function, so you kind of underdevelop that fat-free mass. So you might have normal fat mass, but your whole body mass is reduced. And then if you look at a body fat percent, when you take your fat mass divided by your fat and fat-free mass, that value is going to seem really high. So you're going to come across as having more body fat than you actually do. But on the flip side, with body mass index, which is a very common thing, you're going to come across as having a lot less body fat than you actually do. And then if you take body fat and you measure it with skin calipers that, you measure the thickness of the fat underneath the skin, that's going to underestimate body fat, because individuals with cerebral palsy are actually partitioning fat stores towards the deep abdomen section, which is a lot more dangerous than the fat underneath the skin. And individuals with cerebral palsy partition more fat storage to the muscle sites and the bone marrow sites. And this is all more deleterious or harmful to metabolism and just body physiology than what happens underneath your skin. So you're measuring the skin fat thickness, and that's not really where the problem exists. So yeah, depending on the measure, you're either too fat, not fat enough, or just right.
It's a real Goldilocks problem.
There it is. That's right.
And it sort of goes back, Dan, to what you were saying about, it's like a parallel to the test for kidney function, that it's
right.
based on this other thing. We're kind of on a parallel track, but it's a different track than everyone else. And we just need to be a bit more mindful of the fact that we're in this different space, and maybe ask more questions and get a few more people involved in our care, which then, going to what Ed was saying about hoping that telemedicine takes off even more, maybe combined with that, between the accessibility of doctors' offices, the sheer weather problems of the winter, the pandemic going on, all of that. So everything kind of interplays with everything else.
Jocelyn, but I'm going to say something here that, I just way too obvious, but I'm going to give it a twist for this webinar. The secret to losing weight is to be more active than you eat.
Mm-hmm.
Be more active, eat less. I like to think a lot about the idea that steps are life. Like whenever I forced to park a little bit further away, I say, that's okay, steps are life. I think that there's a lot that's driving us to be a lot more sedentary. People are very sedentary, and people with cerebral palsy tend to be more sedentary than other people.
Mm-hmm.
And this Zoom world, I had a whole clinic today, and I had to keep reminding myself to get out of the chair once in a while because my clinic was telemedicine. I really could have sat down in this chair at 8 o'clock and gotten up at 6:30. Not counting certain biologic needs, but aside from that, there's just more driving us to be sedentary nowadays. So think about how many steps you take some extra steps. Think about how much you're eating, maybe eat a little bit less. I just heard a report on the radio that says that food purchases are way up. We're eating much more food.
Mm-hmm.
We're emptying our refrigerators a lot more and sitting around in front of our computers a lot more. I think we all have to think about that, and especially if you have cerebral palsy, where you tend to be more sedentary.
Yeah, and the sedentariness, I think part of it comes from the fact, speaking from experience, that just being a person with CP is more tiring. So you're constantly having to manage your energy levels, and working out takes more energy. And it's like, what is the sweet spot between gaining something positive and gaining energy from working out, and like being completely exhausted from having worked out? And I actually have a question that's sort of related to what we were talking about. It's from someone who has hemiplegic CP, and they addressed this in their question. They said, being more sedentary than usual over the last 2 years caused several of my muscles to tighten again in my leg and arm and cause pain when doing certain things. Are there exercises I can do to loosen muscles that don't make the pain worse? And then I'll add something that kind of piggybacks off of what Ed said and is a little bit of a different perspective. I have spastic diplegia, so I can walk, I can do stairs, I can move with my legs. What are some alternatives that you can give to someone who doesn't ambulate at all or much and has sort of limited use to their limbs, where like movement is still helpful for them. So what advice can you give both the hemiplegic person who has all these additional issues from the pandemic and maybe someone who's a bit more affected by their CP in all of their limbs?
Those are really good questions, and they're things that we see in clinic all of the time. I think there's a couple different things to address with those questions. But first of all, I've seen a lot of patients who during the pandemic maybe used to work outside of the home and now are working from home. And that's exactly what has happened. Like muscles have gotten tighter, people have gotten weaker, starting to lose a little bit of function, nothing huge, but slowly just some diminished function and more pain, tighter muscles. And I think I put a plug in for physical medicine as a field in general. I don't think everybody with cerebral palsy even knows about our field. And this is a field that looks at function, but even if you're not specializing in adults with CP, many physiatrists, if they do neuro rehab, they'll have seen adults with spinal cord injuries, spina bifida, brain injury, stroke. So very similar, neurological problems that can cause something that looks similar, just that somebody had an injury. And they would be well-versed in treating and assessing like the muscle spasticity, looking at function, looking if there's some other joint problems to address, and developing a holistic plan to include maybe physical therapy, medications, maybe Botox injections. I think that was brought up as a question.
Mm-hmm.
Those things can all be done as part of an overall rehabilitation plan.
I appreciate all of that, especially because, depending on the way your CP is diagnosed or if you have other co-occurring conditions, your main quarterback in your medical experience as someone with CP is either going to be like initially an orthopedic surgeon or a neurologist. And I didn't hear of physiatry until I was 20 something. And I know a lot of others with CP haven't heard of it. This talk might be the very first time that they have. And I think it's an incredibly valuable perspective and relationship to have. And the more we can do to elevate it and get the word out in the CP community, the better.
Right. I think Mark Peterson and I had received an email. I think Mark received an email from somebody and then he forwarded it to me to include. Mm-hmm. And this person had asked questions about one of their siblings. And obviously you can't provide medical recommendations over the internet, but I said, look for a physiatrist. Here's some questions to ask. Here's what to look for. And just recently received an email back that they had found a good physiatrist and a good physical therapist and things were going in a better direction. So it was very rewarding to hear that even just that little bit of information, finding the right person is so important.
Finding the right person is so important. That's just, I'm going to echo it because it's true. I've been lucky to find the right people in my life to help me with things. And so I'm glad that you and Mark were able to help with that. And to kind of go back to the Botox question, because you brought it up and we saw it in the chat, someone asked, their daughter tried Botox. Do you think it's helpful? Do you suggest anything else? I mean, you can't give medical advice. And I know Botox is popular for different reasons for different folks, or just botulinum toxin in general. Mm-hmm. Do you think it's helpful overall? Is that something you feel comfortable answering? And if not,
I think it's part of the tools that we use. So used in the correct patient in the correct way as part of a rehab plan, it can be helpful. It's not an answer in and of itself. It usually needs to be done with other things.
Okay.
I don't know if Dr. Hurwitz has any other.
Yeah, so I think that's the really important concept, Heidi. I've heard people ask, what do you think works better, botulinum toxin or selective dorsal rhizotomy? And the answer is, well, those are like two completely different things, and they're all they're tools in the box, quivers in the arrow, arrows in the quiver. I mean, whatever metaphor you want to use, but and then some people say, oh, botulinum toxin injections don't work in adults. So the answer to that is that that's why you need a good physician, a good, especially in physical medicine rehabilitation, there is no generalizations here. Everybody is an individual, and botulinum toxin has a certain thing that it does. And someone who's used a lot of it, like myself and like Heidi, can look at you and look at your muscles and tell you what we think botulinum toxin injections can do. And then we can talk about, is that a good idea for you? So looking at it generally is not going to be as good as talking to someone about your specific case.
Thank you for that. I have a question for Dan. Is bone fragility level as unique as each case of CP, or is it a more general thing?
That's a good question.
Yeah.
As the researcher inside me, I would say it's very unique, even within the individual over time, but that might not be very practical. It's probably somewhere between individual uniqueness to generalize per certain groups or something like that. Yeah. There's a lot of different ways in which the bones can be developed. There's a lot of different ways in which the bones can go on a path towards fragility. And it's surprisingly multifactorial. And it's something that even the bone field is wrapping its head around. So it's very complex, and it's going to be very complicated in the context of cerebral palsy.
So if someone, is hearing this information and wants to at least speak to a specialist about their bones, who are the best specialists to speak with about this?
Like clinicians?
Clinicians.
Oh, that's
that
a good
rheumatologist?
question.
I can give a stab at that if you want.
Yeah, please.
I've referred a lot to our colleagues in endocrinology
Okay.
here at the University of Michigan. They're very good about doing a thorough assessment and not just looking at one thing, say like the bone density test. They won't just look at that and say, oh, that looks bad, let's put you on meds, but they will do a full assessment and look at risk factors, look at special laboratory tests, and decide, not only do you need medication, but if so, what medication do you need and how long do you need to be on it? Because some of these medications, when somebody's in their 20s, the question is, all right, how long do we give it? When do we stop? How do we use it? And so they are more skilled than that than we are, but I will make many referrals to the endocrinologist.
Okay, that's helpful because I was like, who's the bone doctor in this case? Like there's a few different avenues to go down. So that's helpful to know. Another question in the chat is, if your mobility has declined, do you have any key tips on how to optimize the skills you do have as you grow older, especially if you have no specific CP services nearby?
An interesting question. I think that the first thing I would say is that I always think a good exercise regimen is helpful to prevent mobility decline, no matter who you are, whether you have cerebral palsy or not. And when I say that, I think that people should think about exercise as something where you make little gains, small gains at a time, and even just for the sake of maintenance. There is a lot you can do with stretchy bands and small weights and things like that in the home. Yeah, there you go. Thanks, Jocelyn. And just to keep your muscles active and just to keep your muscles maintained can be helpful with that. But then the other side of that question is to say at a certain point, I'm going to put an emphasis on my life, on my being social, on participating, on being with family and friends and doing the things I like to do. So I'm going to use, powered mobility from time to time. I'm going to use wheeled mobility from time to time. I'm going to go out and get a disability parking thing. I'm not going to be such a hero. I think a lot of kids, their parents beat into them that they got to walk. I still remember a 25-year-old that I told her that, we should really talk about powered mobility. And she looked at me and said, Dr. Hurwitz, for the first 25 years of my life, you and my mother did everything you could to make me walk. And now you're telling me finally I can use. I actually felt really bad about that. So, that's where I say, that's where you out there help me be a better doctor. I'm different after that appointment. So yeah, you have plenty of skills left, even if walking is either really, really hard or you can do it. But as Jocelyn said, it takes all of your energy so much that you can't think straight afterwards. Let me say one more thing about that. You may think about, you may be working with a doctor who says, oh, you're having trouble walking because you're spastic. Take some baclofen. And, baclofen is right for the right person, but baclofen does a lot of things to you that impair your ability to drive and to look at a spreadsheet and other things like that. It sedates, it affects the mind. So sometimes there's the trade-off. You really have to look at the trade-off and decide what's really important. What's my goals rather than what can I do to make myself less spastic.
Mm-hmm. That's helpful. It's a lot. I mean, my mobility and ability has changed. The pandemic definitely has done something. So that's been fun. So I empathize with the person who asked that question. And my non-medical, just personal recommendation is whatever small things you can do them, because they're better than doing nothing. And even if they feel like small, they're something. And don't berate yourself if you don't do anything for a bit. Like, kind of in tandem and sort of opposite to what we were saying, there's like shame kind of added sometimes. If you can't do a thing, or if you don't do a thing that you were supposed to do for your health, like if you don't do it for a day or a week, you're having a rough time, like that's okay. Just each day is a new one. And if that's the day you're going to pick up the resistance band that's sitting on your desk and, use it as resistance on your legs or use it as resistance on your hand or arms, then that's a day that you're doing something and not a day that you're doing nothing. So think of it in little increments. That's my own personal side of things.
I couldn't agree more.
Thank you. Okay. Someone asked, and I don't know if anyone has this answer, but you're in the research space. So do you know if people are working on other things besides and or in addition to Botox for the future? I know Ed just mentioned baclofen is something, there's trade-offs with a lot of things. So if you know of other medications or treatments that could be in the toolbox, obviously not as specific recommendations, feel free to share those.
Well, there's different things going on looking for treatments for spasticity, and there's different things that are going on to look for ways we can help nerves to function better, muscles to function better. But I want to come back to the work that we're doing at Michigan, which is really about how you can function better as a human being. And I want to give Dan maybe a chance to talk about that a little bit. Just thinking about, Dan, some of the things that we'd like to do to help people with their bones, to help people with mental health, and some of the work that you've done looking at some of these issues. And maybe you'd like to comment about how your work is directed toward making people higher quality of life, and more so than thinking about a Botox injection.
Yeah, one thing we really want to understand is the healthful or unhealthful aging process. What's happening when, to who, and why? And once we have a better understanding of this sort of integrative physiologic or integrative approach of the individual as a whole, rather than just saying, oh, this person, let's look at their bone and nothing else, or let's look at their depression or loneliness levels and nothing else. There's a lot of integration. So really understanding this from an integrative approach will give us a better idea of how best to start addressing some of these issues here. Is that what you were thinking, Dr. Hurwitz?
Yeah, absolutely.
Yeah. One of the things, as somebody who works at the VA, they have something called whole health that I think is something, it's a integrative approach where you are the driver of your own medical care and you set the goals. And they use many things. You set the goals with your provider, but you include alternative therapy, counseling, yoga, all of these other alternative treatments in addition to regular medical care to help you function and do what you want to do for your life. And I think that idea is hopefully spreading over into regular traditional medical practices also.
That is fantastic. That needs to be everywhere.
Right.
Yeah, and I've talked about this with Ed before a little bit. Like part of it is that your physician is the person who's a point person and needs to take over sometimes, but you're ultimately the leader in your own health and the point person in your own health, and you have to advocate for yourself, whatever that means, or assist your loved one or child with advocating for themselves. And I know that it can be exhausting. And on the days when I'm exhausted by it, I like to focus on the fact that it's empowering and that I'm doing this thing for myself that no one else is going to be able to do, or that I'm doing, or that someone would be doing this for their loved one because their loved one isn't able to do it. And really turning the paradigm on its head would be fantastic. We just have a few minutes left. So if any of you have final thoughts you wanted to add before I close this out, feel free to share those.
Dan, anything you'd like to say?
Nope, not that I can think of.
I think I kind of wrapped up most of what I wanted. I think just piggybacking on Dr. Hurwitz with what you said about the mobility and talking about fatigue and energy conservation, finding that balance is so important. And I have so many conversations with people, letting them know that walking is not the only way you need to get around in your life. And it's okay to use assisted mobility, and that it's not a failure.
Yeah, and it goes to what Ed was saying earlier as well, that, you know, you're kind of taught a certain way and then realize, oh, there are also other options and I should just do the thing that conserves my energy the most so I can enjoy whatever it was I was trying to do. I just want to throw in, someone just mentioned, I know there's a few folks in here from Ireland, and someone just said they really feel the lack of medical support for adults with CP in Ireland. So I know we're talking US centric, but that's also something to keep in mind, that we're not in a bubble. Sometimes it feels like it. But there's lots of other medical systems around the world that are either not totally helping adults with CP or doing a little bit of a better job. So I wish there was something I could say. If you know any other information or resources you could share with them.
No, I don't, Jocelyn. Let me just say one final comment that I really want to praise the work of CPARF and groups that are similar to CPARF. I think one of the great needs, I mentioned the great needs for greater capacity for care, for more physicians, therapists, and so forth that are trained. We also need more research. You know, autism did a great job of promoting itself in terms of research dollars coming in. People say, you know, it was autism speaks. I always say autism screamed. So cerebral palsy has to scream a little bit too. Everybody in America has a congressman and a couple of senators. You can email them quickly. You know, it's not that hard to do, and look who they are and send them emails telling them that it's important to include cerebral palsy funding in the NIH research and in other research. There's already been some legislative work that's done on that based on the advocacy. So we have to keep the advocacy up and going. Advocate for, you know, that there be funding for research, advocate that there be more education about people that grow up with disabilities like cerebral palsy. I think all of that is important roles that each and every one of us can play.
I appreciate that reminder. It goes back to the advocacy on a completely different level, from the sort of smaller personal to the bigger macro level. And, you know, as we're closing in on 6:30 over here, I just want to thank Heidi, Ed, and Dan so much for such an enlightening conversation. I've learned so much from you, like I knew I would. And a special thanks to everyone who submitted questions, because your openness will help the entire cerebral palsy community. If you want to learn more about CPARF's work, the research that Ed alluded to and that I mentioned earlier, you can visit us at www.cparf.org. And on our homepage, you can sign up for our mailing list and find out different ways to get involved. When you give back or you amplify our work, you'll be taking the future of cerebral palsy research into your own hands. And before I let you go, I'll just share that we'll be posting this online in case you know someone who missed the webinar or you came late or you'd like to rewatch it. So keep an eye out on our social channels for the link. Thanks again for your time and enjoy the rest of your night or day, depending on where you are. Take care, everyone.